All right, so you're going to need to know about imaging for the renal system. Um, and basically, what you need to know is like what's dangerous, okay? So, the first condition, or not, I shouldn't say condition, the first test is a renal biopsy. And the reason it's dangerous is because the kidney is very vascular. Okay, so you need to, beforehand, make sure you have coagulation studies. Okay, they're going to need to be NPO beforehand. All the stuff you need to do the pre-op checklist, informed consent, timeout. You're going to do the coagulation studies. Now, you're going to position the patient prone with pillows underneath their abdomen and their upper shoulders. Okay, and then you're going to have the patient hold their breath during the procedure. And the reason for that is to prevent a pneumothorax. Now, the patient is going to need to be on bed rest after. You're going to have to hold pressure for 20 minutes, and you're going to want to make sure the patient is quiet because you don't want them to bleed out. And the most important thing is you need to monitor for a UTI after. So, a couple days after, you're going to start monitoring for that. They're going to have rosé or hematuria in their urine couple days after, up to a couple days after. And then also, you never want them to get hypertensive because if they get hypertensive, they can start bleeding. So you should suspect bleeding if they have a Gray Turner sign and all those signs we've been talking about with low perfusion. KUB is just a regular x-ray, and they would do this to look for obstruction and just, take off jewelry and make sure the patient is not pregnant. With the CAT scan, this uses contrast dye, so we need to protect the kidneys. With MRI and CAT scan, the CAT scan dye has iodine, so you do need to ask about a shellfish allergy. The MRI contrast dye does not have iodine yet. It's still neurotoxic. So the same kind of interventions. Okay, so with a CAT scan and an MRI, you're going to check the BUN and creatinine, hold the metformin 24 hours before and 48 hours after. They're going to need flushing fluid if they have like a high BUN and creatinine. So normal saline is the flushing fluid. And then they can get some medication to protect their kidneys. So the IV fluids of normal saline with an amphibicarb or plain. And they can also have acetylcysteine to protect them beforehand. You want to monitor the urine output and make sure that they are putting out urine after this test. And then with MRI, it's the same interventions. You just don't have to ask for a shellfish allergy. A renal scan is safe. A renal scan, anytime you hear the word scan, it's a test in in nuclear medicine that they're going to have. And they inject isotopes into the patient and then watch how the isotopes are taken up by the kidney. So it is a safe test in somebody with renal failure. The retrograde pyelogram, okay, this is like a dangerous test. First of all, especially in older adults, so you got to check the BUN and creatinine, make sure they don't get dehydrated. Don't give magnesium-containing laxatives for patients that have kidney insufficiency. They do have to clean them out beforehand so the provider can see the bladder better. So same interventions. They're going to need, the creatinine, the BUN beforehand, fluids, etc. And then the renal angiography, it's the same nursing implications as a cardiac cath. All right, you're going to have to be able to distinguish hypokalemia and hyperkalemia. So remember the signs and symptoms of hypokalemia, like the hypotension, decreased bowel sounds or hypoactive bowel sounds. And on the ECG, you'll see a U wave, and your patient can also develop PVCs. Okay, so both either hypo or hypo can get a first-degree block or VTAC. So remember what to do with that. And then with hyperkalemia, we really worry about it in people with kidney disease because they're going to be prone to it. Remember, it's first-degree block widened QRS, PT ways, and a prolonged PR interval. All right, the treatment for hyperkalemia, remember kind, Kayexalate, which is sodium, polyester sodium. I is for insulin, D is for dextrose, or dialysis, and N is for bicarb. Okay, an acute kidney injury. This is a rapid loss of kidney function. So they're going to have some incident, some onset, and then 48 hours later, they could have an acute kidney injury. So like they could have hypotension. 2 days later, their creatinine can bump up. So AKI affects most body systems. Chronic kidney disease affects all systems. The oliguric phase of AKI has the same signs and symptoms as chronic kidney disease. All right, your GFR is going to be your best measurement, which is reflected also in the creatinine clearance. So we use 125 as the normal, so to speak. Now, there's 3 kind of causes of an AKI. So there's pre-renal, which means things that happen before the kidney, usually in the vascular system, like a low perfusion problem. And this is going to be 90% of your renal problems. So remember the 3 Ds, diuretics, dehydration, and diarrhea. Anybody that's had an MI, if the heart's not pumping efficiently, they're going to be at risk. Anybody with an MAP less than 65 or has hypotension, that's what we worry about, that they're going to have a kidney injury. Anybody with heart failure, liver failure because of the low albumin causes the kidneys not to be perfused as well. Burns, same thing. You'll learn about that for the final. But with burns, there's going to be a huge albumin shift, fluid shifts. So the patient's going to be dehydrated. Any kind of thrombus, okay? The patient's going to become anuric and they'll have a kidney injury. The next type of injury is an intrarenal kidney injury. And this is damage inside the kidney. So remember your nephrotoxic medications like your aminoglycosides, furosemides, NSAIDs, cisplatin. Zoledronic acid is a biphosphonate, and we use that to treat hypercalcemia, but it also can and also osteoporosis, obviously, but it can also damage the kidneys. Loop diuretics can damage the kidneys. Lupus, scleroderma, all those connective tissue diseases, diabetes, hypertension can also cause an intrarenal AKI. All right, diabetes and contrast medium. All right, post-renal causes include, it's in the urinary system, so like cancer pressing on the ureters, or like renal calculi or a neurogenic bladder. Okay, so those are post-renal injury causes. Now, with the oliguric stage, you're going to need to know the labs in the oliguric stage, the diuretic stage, and the recovery stage, like which way they go. So in the oliguric stage, usually what happens is they have a urine output less than 0.5 milligrams per kilogram per hour for 2 hours. Okay, they're going to have urine sediment, an S3 heart sound. You're going to worry about that. Once somebody becomes oliguric, your highest priority is going to be the cardiopulmonary assessment, because you want to make sure you're ahead of the game if they go into fluid overload, because they're not putting out urine. Okay, so they may need emergency dialysis. Low O2 sat, anosoccer, and remember the fluid restriction. So 500 to 600 mLs plus the 24-hour urine output. So here are the labs. I'm going to also add with this, the specific gravity may be fixed. So 1.010, we call that 1010. That's a fixed specific gravity, okay? So the creatinine is going to increase, the BUN is going to increase, The potassium will increase, the phosphorus will increase, and the magnesium. The GFR is going to decrease, calcium will decrease, hemoglobin will decrease, and the pH will decrease. So the patient is going to be in metabolic acidosis. Okay, so their bicarb is going to be down, their pH is going to be decreased, and if the pH is not normal, it's probably partially compensated. The PaCO2 is probably down as well. If it's normal and the PaCO2 and the bicarb are low, then it's fully compensated. And the patient will have Kussmaul's respirations. Okay, in the diuretic phase, okay, the patient starts diuresing. So the time frame really, when you get a question, will say the patient's in the diuretic phase, so you don't need to memorize the time frames, but they can put out up to 10 liters of fluid. As they're putting out this fluid, this signals that the kidneys are healing. So the kidneys are getting better. So now you have to worry about hypokalemia because they're putting out a lot of urine, right? You're going to see the BUN start decreasing, the creatinine start decreasing, the potassium decreasing. So all those labs that were up are now going to be down. You will also see the specific gravity increasing. You will see any signs of uremia will start to get better as the patient starts diuresing, and when they get into the recovery phase, they'll be even greater. Okay, so if you see any of these signs and symptoms of low potassium, get an ECG. All right, so the specific gravity is going to start getting better. They'll have a low signs of dehydration. They'll have a low-grade fever. BUN and creatinine decrease, and the GFR should increase. So the patient's going to have weight loss, and they're going to need that fluid replaced. They'll have a low CVP. The best thing is to replace fluids, taking the urinary output into consideration, because you got to put back in what was taken out. All right, so with AKI, they can have dialysis. It's probably not going to be permanent, so they could have like a temporary or permacath put in, temporary vascular access. People that are unstable, hemodynamically unstable, and need a lot of fluid pulled off can go on to continuous kidney replacement therapies, which is, dialysis 24/7. It can be done right through the patient's central line in the ICU. Patient always has to be in the ICU to have this. Continuous venous hemofiltration, needs a pump to, help the blood circulate, and that puts them at risk for air embolus. Okay, so this is for unstable people because they can't withstand intermittent, like they'll drop in blood pressure. All right, this is just talking about the contrast-induced nephrotoxicity that I already talked about. Okay, so the phases of an acute kidney injury. Okay, so you don't need to know the time. You don't really need to know the time frame, but the oliguric phase, the diuretic phase, and the recovery phase. Those are the phases. So you need to know which way the labs are going in each phase and what kind of signs and symptoms you're going to see in each phase. Okay. Now, this is the oliguric phase of AKI and chronic kidney disease. So the brown colored words are signs and symptoms of uremia. Okay, so we're going to worry about fluid overload. Okay, so one of our goals is euvolemia, which means the perfect equal I&O. Also, we don't want our patients to bleed out, so that no evidence of bleeding, that is a great outcome for our patients. We want to maintain adequate nutrition, which is kind of difficult at times for patients with renal disease. All right, so uremia refers to high nitrogenous waste products in the blood. and it's neurotoxic. So you're going to see a lot of the same signs and symptoms that you see in liver disease. Okay. The difference is once they start to get these neurological signs, like they have encephalopathy, they're somnolent, they're groggy, all right, there's not a drug you can give like you could for liver patients when you can give them lactulose, right? And then they, start, losing the ammonia through their bowels. Okay, there's nothing like that for kidney disease except for dialysis. Okay, so once your patient starts having these neurological symptoms, they're somnolent, they probably have like acidosis, they probably have high potassium, but once they're somnolent, have asteristics or one of these neurological signs, they're going to need probably dialysis. They'll also be put on a low protein diet. So here are the signs and symptoms. Remember, it's neurotoxic, so they're going to have asteristics, fatigue, ataxia, encephalopathy. Cardiovascular signs and cardiopulmonary is what you're going to watch out for the most, right? Because you don't want them to go into overload. So they're going to have heart failure signs, CAD. Pericarditis is because uremia is also toxic to serous membranes and mucous membranes. Okay. Peripheral artery disease and cardiomyopathy can occur. Okay, in people with long-term disease. GI, the first signs are vomiting, anorexia, nausea. The first signs of uremia. GI bleeding. People with renal disease are really prone to bleeding for a number of reasons. But it's really, uremia is very irritating to mucous membranes as well. So they have stomatitis, gastritis, and feta. All right, endocrine wise, they're going to have sexual problems. Hematological, they'll have anemia because the kidneys can no longer make erythropoietin, but also when you have a high BUN and creatinine, the red blood cells start to lyse. Pulmonary edema, uremic pleuritis. So remember, it's uremia is toxic to serous membranes. They're going to have pneumonia, tachypnea, and hyperpnea. So hyperpnea means a deep respiration. So if they're breathing fast and deep, we call that Kussmaul's respirations, and they're going to have some form of metabolic acidosis, either partial or fully compensated. Their skin. So the skin in renal disease, they're going to have pruritus. They're going to have yellow tan or yellow gray or yellow brown or sallow, we call it. They have that color skin. They have purpura petechiae. The skin is going to be rough, dry, and scaly, and they may suffer from uremic frost, which is like a frost on their skin due to uremia. They're going to have what's called hand and foot peripheral neuropathy due to uremia, and they will have problems because their calcium goes low and the phosphorus is high. They can be at risk for osteodystrophy. They lose teeth. They can have like pathological fractures, so they're at risk for injury. The labs are going to be the high potassium, high phosphorus, high magnesium, low calcium, low pH, low CO2. Now, this is the bicarb in the electrolyte panel. And then low hematocrit and hemoglobin. Metabolic acidosis, you're going to see that. You're going to see the increased BUN and creatinine, decreased GFR, and a fixed specific gravity. And this is just talking about high potassium that we talked about. Calcium gluconate does not lower the potassium, but it antagonizes the effects of calcium on the heart. You're going to give, dextrose solutions with regular insulin, and then sodium bicarb. And sodium polystyrene, that's going to take time to work. So if you have a choice, if somebody's having like VTAC, you're going to give calcium gluconate right away. If you got time, you can give dextrose and insulin, but definitely dextrose and insulin before your polystyrene. Okay. You want to also, if somebody has a high potassium, you want to question medications that cause high potassium. All right, so ACE inhibitors, ARBs, and K sparing diuretics. So you would question those. And then for a high potassium, you may need to do dialysis. So who needs dialysis? Remember AEIOU. So people with extreme metabolic acidosis, people with electrolyte problems like the high potassium, if they are intoxicated with medications that they can't clear out of their system, if they're in fluid overload and they can't put out urine, they're anuric. And then people with uremia symptoms, especially like the neurological symptoms, right, where they're really somnolent and you know they're going to have encephalopathy, they would have to do dialysis for that. And you know, we've talked about the treatment, signs and symptoms of pulmonary edema, but also the treatment for it, okay? And also keep in mind that patients that have renal disease and they're anuric or oliguric, they're not going to be able to clear medications like they used to. So their normal medications or any medication you're using to treat them can they can have toxic side effects from that. All right, now chronic kidney disease. Now, a chronic kidney disease, this happens over 3 months, and the GFR is less than 60. So it's a progressive decline in kidney function. Now, there's 5 stages. You don't really need to know the GFR in each stage. I'm just going to point out some things you do need to know. So in stage 1, your patient has stage 1. It's kind of like a fact-finding mission. We have to figure out. We have to assess for risk. What caused this? Do you have hypertension? Do you have uncontrolled diabetes? You know, sometimes people don't know what they have, okay? So you do that, avoid nephrotoxic drugs in this stage. And then once you find out, you know, it's like all health promotion and maintenance. So, you know, live a healthy lifestyle. Don't take aspirin or NSAIDs. You want to monitor BP control and ACE inhibitors. Patients with kidney disease are going to be put on ACE inhibitors to reduce protein loss from the kidney, okay? Because once they have kidney damage, they're going to lose protein from the kidney into the urine. So that's why they take an ACE inhibitor. But you also have to remember that an ACE inhibitor is going to increase the potassium. So you're going to be monitoring the potassium. All right, in stage 2, health promotion and maintenance continues. Patients got to live a healthy lifestyle, be the great weight, no smoking, limit alcohol. BP control, they're going to need to take pre-dental antibiotics, and they need to, at this stage, if they can, drink as much water as they can. Now, not everybody can do that. Now, stage 3 is when it gets real, okay? So the kidney's starting to crack here, and this is where they lose more protein in the urine. They need to, in stage 3, they need to restrict protein, potassium, magnesium, phosphorus. They need to start taking phosphorus binders if they're not already on them. I do have a Quizlet, low and high K foods that you can go do, and they will be on a fluid restriction. So you can use the 24-hour plus 500 to 600, or usually it's like 700 mLs per day. They'll be on a fluid restriction. Then in stage 4 is when you discuss their options, okay? They're either going to get ready for dialysis, transplant, or a peaceful death. All right, stage 5 is when dialysis is initiated. So whatever they just, and you know, not everybody's going to get the transplant quick, so they may do dialysis but be on the transplant list. All right, so the GFR is less than 15 here. Now, with the high phosphorus and low calcium, they're going to be sustainable to osteodystrophy. So they may lose teeth and have fractures. All right, so signs and symptoms of hypocalcemia. They're going to have prolonged clotting times, okay? Calcium is used in like every clotting equation. So they're going to be prone to bleeding. They also have diarrhea. Circumoral numbness and tingling, Chavostex, Traciosa, tetany, and the long QT. Uremia, the pericarditis. So remember, it irritates serous membrane. So remember your signs and symptoms for pericarditis. And remember, especially tamponade, okay? So the hypotension, JVD, muffled heart sounds, and that pulsus paradoxus. All right, so people with chronic kidney disease, uremia decreases the WBC production. And iron deficiency anemia because of the decreased erythropoietin, and they also have a folic acid deficiency. So they're going to have a combination of different types of anemia. They have impaired platelets, not necessarily low platelets, but the platelets don't work because of uremia. The GI changes, so remember uremia is irritating to mucous membrane, so they can develop colitis, gastritis, stomatitis. They do get bad breath and hiccups. Sometimes the breath can smell like ammonia, actually. Nutrition, okay, so for anybody with a low GFR, especially stage 5, you're going to restrict, once it gets to stage 3, you start restricting protein. Once the patient starts having dialysis, they need more protein, okay? So stage 3 and 4 is going to be low protein, low potassium, limit foods in phosphorus, low magnesium diet, and restrict fluids. All right, and I told you protein needs to increase once they hit dialysis, okay? To prevent bone disorders, they can get calcium, they can get sevelamer. That's a phosphate binder. So they also can get aluminum-containing antacids. All right, so you need to tell your patient not to take over-the-counter medications. Remember, a lot of times they can get heartburn from the irritation of the mucous membrane, so you definitely don't want them taking magnesium-containing antacids. And they have to check their blood pressure, blood sugar more frequently, because the insulin or whatever medication they're taking is gonna stay in their system longer. All right, so for dialysis, hemodialysis, you need some kind of vascular access. So this is a permacath, goes in the subclavian or interjugular vein. These are usually temporary, but there are some that can be used a little bit longer. You, as a nurse, not a dialysis nurse is the only one that touches that, the line, okay? No fluids, no CVP, don't draw blood from it. Only used for dialysis and minimize manipulation. Now, they will like draw blood and give fluids while they're doing dialysis, but I mean, you're not supposed to touch it. Only the dialysis nurse can. So before patient has hemodialysis, okay, and when I'm talking about hemodialysis here, I'm talking about intermittent dialysis. So a patient goes 3 times a week for 4 hours or 3 hours, whatever their schedule is, okay? So you weigh before and after. Make sure you know the dry weight so that after weight. They're at risk for bleeding for 4 to 6 hours after dialysis. So make sure you have protamine sulfate on hand, but also recognize that the patient cannot have any kind of invasive procedure 4 to 6 hours after dialysis. Monitor for hypotension. It's very common. And then disequilibrium syndrome usually happens because too much, like the dialysis is run too quickly and there's too much sodium taken off the brain and they get cerebral edema, okay? So they'll have decreasing LOC, a headache, confusion, and seizures. So you want to prevent and treat by slowing the infusion. They can get phenytonin too. Hypotension. So you might suspect this if your patient has a decreased LOC or says he's feeling dizzy, okay? So take their blood pressure, and if it is low, put the bed flat and give fluid. So a dialysis nurse, like an ED nurse, has a set of orders, so to speak, that they can initiate. If the patient's hypotension, they're going to give a bolus of fluid to get that blood pressure back up. Anemia. The hemoglobin will go down after hemodialysis, okay? So with anemia, look for sinus tach, low blood pressure. They're going to be on EPO, and AFLA, which needs to be in the refrigerator. You're going to hold or question if the hemoglobin is greater than 11 or if they have a headache or a high blood pressure. Air embolism, we've talked about this earlier in the semester. So sudden shortness of breath and syncope. Stop what you're doing, put them in the left side Trendelenburg, put some O2 on them, call a rapid. Okay, so for more permanent access, they're going to either get an AV fistula or a graft. So a fistula is what the surgeon makes by putting a vein into an artery, and over time it matures. Okay, a graft is like celastic material, like it's a man-made graft. Okay, so they can have that too. The benefit of that is you can use it immediately, whereas the fistula is going to take weeks to months to mature. So once somebody has one of these devices, no BPs, no blood pressure, no drawing labs, no putting fluids through that arm. If they have a fistula, you're going to feel for a thrill. You're going to auscultate for a bruit to make sure it's patent. You're going to check for the 6 Ps, so you're going to do your neurovascular checks. Encourage range of motion. They cannot wear watches. They cannot sleep on that side. I don't know how you prevent that, but that's really an intervention you're supposed to do. Don't carry heavy items, and make sure it's clean. And then here's a gnarly looking one. They can get quite big after a while. And sometimes you can have a patient that has like 3 or 4 that failed, and so they've had other ones put in. Steal syndrome, you would watch this. So it means the fistula is stealing blood. So you would have like cool hands and numbness and tingling, and it would be very pale, and they would complain of pain and have slow cap refill. All right, now peritoneal dialysis, there are some contraindications. People that have like adhesions, like maybe they had surgery a long time ago and they have adhesions, and people with polycystic kidney disease cannot do peritoneal dialysis. Good candidates are people that can take care of themselves and understand the procedure and learn about it. Older adults and people that can't have anticoagulants. You use a lot of heparin in hemodialysis. So if you can't have anticoagulants, peritoneal dialysis is going to be a good choice for you. So there's a ton of different methods to give peritoneal dialysis. We're just going to talk basic, because seriously, you could take 3 or 4 classes to teach about dialysis. It's a nursing specialty, but I'm just going to teach you what you need to know to be a med-surg nurse when you're starting out, okay? So peritoneal dialysis involves filling the peritoneum with dialysate, letting it dwell. The provider orders the dwell, so dwell 20 minutes, and then you drain, okay? So that's one PD exchange, and people could have several over the course of a day, and some people do it continuously, all right? So the drain is effluent or outflow, we call it, that's what it's called, and it drains by gravity into a collection bag. So the complications of peritoneal dialysis are there's more protein loss. So people with peritoneal dialysis have to eat more protein than people that have hemodialysis. And people in stage 3 and 4 obviously have to have low protein. It can cause a high blood sugar because the dialysate has high concentration of sugar. It can cause peritonitis. So make sure you remember the signs and symptoms: the board-like abdomen, tachycardia, fever, guarding, abdominal distension, and then perforated bowel. Okay, they can get infections, they can get weight gain. The interventions for outflow, okay, first you're going to check for kinks, and then you can start rolling your patient from side to side. You want to make sure their body alignment's good so it drains, right? Because it's a gravity drain, so you have to drain to gravity. You want to know if your patient's constipated, because that can slow down the drainage. The benefits are the patient can travel, all right, but it does take longer to do. So although they can do it at home, it takes longer. The hemodialysis is like 3 or 4 times a week for 3 to 4 hours. Whereas this is every day on a set schedule. It could be several exchanges per day. All right, so those are kind of some of the they have fewer dietary restrictions. They still need to take a phosphorus binder, and they cannot have salt substitute, and they can develop hyperlipidemia. Peritonitis I talked about. So with peritoneal dialysis, it's a sterile procedure. This is kind of blew my mind, but hemodialysis is a clean procedure. So there's not as much sterility that's needed with hemodialysis. So for a transplant, 2 to 70-year-olds can get transplants. They'll first have a urinary tract evaluation, same criteria as a liver transplant. You know, they have to do like all that psychological testing to make sure they can take care of themselves. All right, so just regular skip guidelines. The kidney, interestingly enough, is placed in the iliac fossa, okay, right here. So when patients get a kidney transplant, if they're going to have a reaction, the patient's going to feel like lower abdominal pain or groin pain. That's where they'll feel it. And they put it here because it makes it easy to palpate, and also easy to get to if they need to be operated on. All right. Okay, so post-op care is very important. The patient's going to be at risk for infection because, you know, they take all those medications, so they'll be in protective isolation. You're going to watch out for rejection. They're going to have diuresis. So when they first come out, this is important. The urine output is checked hourly, and this is the parameter you use to give fluid, because they're going to have, you know, you need to put in what's coming out. All right, so that's the most important parameter to base your fluids on. You don't want to give the patient an AKI on their new kidney, so that's why you have to stay on top of it, and watch the diuresis. All right, they can get like a thrombus, so you would see a fever early on. Titrate the fluids to urinary output. Early ambulation is important for every major surgery. Okay, now, unlike other types of transplant, the kidney has what's called an hyperacute reaction. Happens within 48 hours. They're going to have a fever, extreme hypertension, and pain at the graft site. The only thing they can do about that is take the kidney out. And then acute rejection can go 2 days to up to 2 years. Okay, so the patient's going to get oliguric. Now, let me tell you what happens with the rejection. The patient's going to have all the same signs and symptoms of kidney disease, right? Plus, they'll have a low-grade fever. They're going to have tenderness at the transplant site. They're going to have hypertension, high white count. They'll have a high BUN, high creatinine, maybe a fixed specific gravity, and a low GFR. What they'll do with this is to try to increase the immunosuppressant drugs to see if they can, you know, stop the kidney from the body from rejecting the kidney. A chronic kidney rejection happens over years, and so what they do with chronic is they just kind of let it ride out. In other words, they continue on their regular immunosuppressant, they have conservative treatment, and they're going to have a gradual return to chronic kidney disease. And then they'll probably have to go back on dialysis. Patient teaching for immunosuppressant medications, avoid crowds, hypertension. The drugs are nephrotoxic, so you have to be careful. And they need to adapt a healthy lifestyle. They need to engage in surveillance of malignancy, because this is like the worst thing that could happen with somebody on immunosuppressant drugs, because if they get cancer, it's going to be very hard to treat on those drugs and have to have chemotherapy, and no grapefruit juice. What else do you need help with, Catherine?